Hello, good morning, everyone. This is Gloria Zaionz. I am the technology guru for the Innovation Learning Network. We are very excited to bring you today's Tech Tuesday, Exponential Tech at the Gate, Exponential Thinking Comes to Healthcare. But first, there are a few housekeeping items that I'm going to take you through. First, you have been muted upon entry to avoid background noises and disruptions. Second, we will hold off on Q&A until the end, but you may feel free to use the chat box during the presentation for questions and comments. And as you do so, please make sure that you select everyone from the drop-down menu. Cynthia and I will be monitoring it. And last, this presentation is a contribution to the ILN, which means that you can live tweet throughout. Now, I would like to introduce our presenters this morning. We have Daniel Kraft from Singularity University. We also have Lucien Engelen from Radboudumc REshape Center, and John Mattison from Kaiser Permanente, and myself, I will have a brief summary at the end. And with that, I'm going to hand this session over to our very first speaker this morning, Daniel Kraft. Daniel?
Greetings, everybody out there. I'm going to try and share my screen. And I'm lucky to start this off with a 10-minute quick intro to exponentials, exponential technology mindsets and how they apply to healthcare, both today and in the future, and how that might be relevant to all of us, whether we're physicians or patients or technologists, across the whole spectrum. So it's a pretty interesting time across technologies. Many of them are moving very, very quickly, from AI to machine learning to robotics to drones. And I think we have a real opportunity to start applying many technologies that weren't in healthcare to health and medicine across the healthcare spectrum, from health and prevention, keeping us healthy, health span, to early, more low-cost diagnostics, to the future of therapy, more tuned and personalized, to global health, democratizing healthcare, even discovery and clinical trials. So before we dive into exponentials, just a little bit of a mindset check. In most parts of the world, we don't really practice healthcare. We practice sick care. What do I mean by that? We're still very siloed in terms of the way we practice medicine. I, as a physician, am trained in internal medicine, pediatrics, and hematology oncology. That's often in one bucket. We have cardiology, immunology, all the ologies often separated. The data often is siloed between medical records that don't talk to us. And so often our sick care system leads to intermittent information that doesn't flow, and very reactive sick care, where we wait for the heart attack or stroke or tumor to come along at a late stage. And I think the potential with many exponential technologies is to bring them together to enable the information and data to flow, to be more actionable, and hopefully much more proactive, personalized, and tuned. And again, to democratize that technology and access around the planet. So a few examples of exponentials. Of course, we have a lot of new tools in health and medicine. One of them I'm holding here. This is actually antique. It's an iPhone 2, almost 9 years old. It's only been 10 years since the first smartphone came out. And these, of course, have exploded in healthcare. They're really exponential technologies we have in our pocket. This smartphone, even the iPhone 2, which would feel slow and clunky in today, has about 1 billion times the price and speed of performance of a supercomputer in the 1970s. And of course, what's the iPhone 10 or 12 going to look like? Here's a sneak peek at the 10 and the iPhone 11. Bit of a joke, but clearly it might be even difficult to imagine with the smartphone, if it even is not embedded in our contact lenses or in our augmented reality displays in 10 years from now, what those might look like. But again, these are powered by an exponential technology, Moore's law, the power of computing getting faster and cheaper and often doubling in price, lowering in price and doubling in speed and performance every 18 to 24 months. And that's the classic example of an exponential technology. And I'll explain what I mean by exponentials, but it's sort of almost the opposite of linear. We can all think linearly, 1, 2, 3, 4, 5. If I took 30 linear steps, I would be across the room. That's 30 steps. But 30 exponential steps is harder for our minds to grasp. 1, 2, 4, 8, 16, 32, 64, 128, 256. You can do a few in your head, but as we get to 15 steps, we're at 32,000. And as we reach 30 steps, we're at 1 billion. That's 26 times around the planet. That's the power of exponentials, which is often sort of hard for our brains to realize. It's often deceptive where we are in terms of where technology is today and where it will be in 2 years, 5 years, and 10 years. Because, you know, the iPhone 2 versus the iPhone 7 versus the iPhone 17, just examples, are going to look quite different and hard for our brains to grasp. So, you know, back to the Apple example, you know, the desktop of 2000 now fits on my smartphone, now fits on my smart watch. We're now seeing computers the size of a grain of sand that have the power of my smartwatch. And of course, these are being connected. You've heard of the Internet of Things. Internet of Medical Things is exploding at an exponential rate. And the ability to connect those data points is also exploding. We're here in the era of 4G network. We're coming to 5G, which won't have 2 times or 10 times, but we'll have 100 times the speed and bandwidth of our 4Gs today. And that will be here in just a couple of years. So many things are moving quickly. And in healthcare, that gives us, I think, the opportunity to reconnect the dots, to make sense of not just siloed information, but to use it in interesting new ways. It's often called connected health or mobile health or digital health. They're all kind of buzzwords. I think we'll just soon call it health. But it is bringing exponentials together from low-cost genomics and AI and machine learning, and hopefully bringing that to you as a patient or a technologist, or to me as a clinician or someone running a hospital or a clinical trial. So when we're thinking exponentials, don't just think Moore's law. Think of many fields that are moving quickly, from big data, machine learning, to 3D printing, to VR, to synthetic biology and genomics, all coming and converging. So it's not one technology that's moving exponential, it's many of them, and they're coming together and enabling us hopefully to mash up these technologies to address big challenges we have in healthcare, from our aging population to issues with access to care. No matter what happens with Obamacare or Trump care, we have a shortage of doctors and nurses and specialists in many parts of the world. We have a lot of exponential data, but how do we make that useful and actionable? We have a lot of waste. We're still using fax machines to communicate. And we still have our friends at the regulatory bodies like the FDA who are still mostly in the linear mindset and have the struggle of getting exponential, as well as the payers who reward innovations. So we're starting to see exponentials come together. We're now seeing there's dozens of Ubers for health, putting together the ability to press a button on your phone and call for a doctor or a nurse. That's sort of exponentials integrated into our smartphones, touching healthcare. We're seeing new ways that might disrupt insurance. Pharma is being impacted in many ways. What's the future of the N=1 drug? We're in the era of, you know, press a button and drugs are delivered to your home. Amazon, you know, is getting into healthcare. That's scary for many folks, and they're an exponential company. You know, and if you're not thinking exponentially, you might be the next Kodak. Kodak famously invented digital photography, but didn't want to get in the way of their film sales. They went bankrupt and had their Kodak moment. So I think the bottom line for all of us is, as we're trying to re-innovate in healthcare, don't be blind to exponentials. Uber yourself before you get Kodak. So I get to play a role looking at exponentials. I chair the medicine side of Singularity University since I started about 10 years ago. You can learn more about Singularity University at su.org. Our mission is to bring smart folks together to understand exponential technologies, how they're converging, and how we might impact technology, impact education, poverty, environment, and healthcare. And about half of the new programs that have evolved out of SU have been focused on medicine. 6 years ago, I started a program called Exponential Medicine to bring folks together across the spectrum to understand the power of exponentials, how they might blend, and how we might use that to reimagine and reinvent healthcare. That program has grown more than exponentially. We meet every fall at the amazing Hotel Del Coronado in San Diego. We have some amazing faculty joining us, including some of our core faculty. You'll be meeting next, Lucien Engelen and John Mattison, who've been with us for several years. And it's pretty incredible when we bring an amazing set of physicians, pharma, payers, patients, technologists together to explore the cutting edge and ask, where can we take healthcare in the future? So there's our Dutch crew. Hopefully you can join us there. The website is exponentialmedicine.com. It'll be this November 6th through 9th. And we can even use exponential technologies like drones to take pictures of our crew there wearing scrubs. So in my last 2 minutes, just a quick taste of a few exponentials at play. First, in health and prevention, we're now wearing exponential technologies on our wrists, the ability to collect our healthcare data across the spectrum. We're moving from quantified self, just measuring our own data, to quantified health, connecting back to our healthcare systems, where we can have our own check engine lights for the body and hopefully give us our own GPS guidance and integrate data. We're seeing augmented reality explode on the scene, from allowing surgeons to see through our bodies, layering data, all the way to patients and surgeons learning to educate based on these platforms. So AR is moving quickly. Augmented reality for educating our kids, to see inside their bodies. These are amazing technologies, would have seemed magical 10 years ago. Now my son can learn anatomy on these. We're seeing, of course, the advent of personal genomics. The price of sequencing is dropping at twice the rate of Moore's law, from millions of dollars to about $1,000 today. You can get your own genome on a disk drive. You can even use low-cost 23andMe type platforms to look at your risk for disease, your pharmacogenomics. We're seeing the first app stores for our genome being launched, like Helix was announced a few weeks ago. So incredible exponentials coming together. Microbiomes you can do for $80. Lots of biologic data. The trick is, how do we put that together? Diagnostics. We now have our digital doctor's bag. Lots of things I have right here next to me that can basically replace what required a whole clinic in the past. So exponential technologies are bringing us diagnostics and blending with artificial intelligence so that we can look at an eyeball but then use AI and machine learning to understand what's underneath the hood. So I think we'll move from AI to IA, intelligence augmentation, and these platforms are moving very quickly to enable us to do quick diagnostics anywhere we are. Therapy is moving in exponentials. We can prescribe an app and democratize access to basic information. We can now integrate diagnostics and therapy into a small pill. The eye pill, for example, many exponentials coming together. Our pill bottles can talk to us through the Internet of Things. Gene editing with CRISPR is moving at exponential rates. 3D printing is moving quickly. That's not always an exponential technology, but getting to the point where we can print ourselves and casts and beyond. And now, finally, we can bring and leverage this exponential medicine together. Just like 10 years ago, we couldn't imagine driving without our smart maps like we have today with Uber and with Google Maps and Waze. We can probably take the crowdsourcing of healthcare and move that data into the future, integrating all these new technologies to improve the health and medicine around the planet. So think exponentially, think about convergence of these exponential technologies. Don't think about just where we are in 2017, but as exponentials move quickly, where things will be with AI, machine learning, 3D printing, nanotech, and beyond in 2020, 2025. And I think if we have that exponential mindset, we can move from our sick care system to a much more proactive healthcare system around the planet. And we can all take not linear steps and get out of our linear mindset set to take exponential steps and boldly create a better future for healthcare around the planet. So that's my 10-minute intro to exponentials. I'm going to hand it over to Lucien and stay around for questions. So thanks very much.
Well, thank you, Daniel. I'm not going to try to share my desktop. I think that somebody has to switch it for a second. Okay, that's it. Thank you. I'm sharing my desktop right here. So thank you, Daniel, for this great introduction. I invited Daniel in 2011 to our very first TEDx in Maastricht with a 1,000-seat venue to blow away people just before the lunch and I think it was in 20 minutes, 400 slides to get people out of the arena into the lunch and really think about everything that was going on. At present, I would like to share some of the stuff with you about what we call GNHIC. And GNHIC is a global network of healthcare innovation centers, which we try to work on since 2015, actually at the conference of Daniel, where I met a lot of people who were running an innovation center in the US or more abroad. And it appeared to us that almost each and every one of those ran into the same hurdles. Not only about the linear versus the exponential stuff, but also about the hurdles and the battles that some of us have to fight together with our friends at HR, where we cannot hire the people that are used to work also within startup systems and now in big corporations, where tech transfer still is only looking into valorizing from a money perspective a lot of the things, but we also see the benefit of doing it differently, and also the ever-going debate on what's the KPI of innovation, for instance. So talking to a lot of people at Daniel's conference, and he was also very nice to connect me to some of our colleagues over there, we gradually thought it might be a good idea to combine this. Since healthcare is globalizing, healthcare innovation should be globalizing as well. And a lot of our colleagues were working on exact the same problems, for instance. So that's why we convened at the end of 2016 at Exponential Medicine in a small room where we thought that 5 or 6 people would show up, and turned out that 35 people showed up to talk about this. And when Zeina Kayat, who joined us for a secondment this year from Mars, from Toronto, stepped up to our REshape team, I asked her to take GNHIC to the next level as one of her 3 projects. So what we see is that there's a massive potential for impacting exponential technology, of course. And like I said, the uptake is more from a linear perspective in regular health than in the exponential version, as Daniel shared already. And we also might need new methods, new design principles, new vocabulary and mindsets, and maybe even also those KPIs that I was talking about. And that's where we said, well, how to operationalize this. Let's try to create a community of practice where we not only could explore and also tackle systemic barriers, but also could share. Why should we spend the same dollars over and over again because somebody in Singapore is doing exactly the same as in Palo Alto and the same as in Sweden or in Nijmegen, for instance? So why again and again reinvent that same wheel? And that's why we start recalling all the people that were at this very first meeting at Daniel's office. And Zeina, together with Jules, one of our other team members from REshape, literally called each and every one of them. And these are the organizations and companies that signed up to be part of the first cohort of founding members of GNHIC. We try to, thing that we try to do is that we try to create a value proposition for everyone, where we try to demonstrate the innovation and technology leadership, but also to combine everything that's happening on a worldwide frame for that, of course. I won't go into the detail of the design principles. As Gloria said, we'll be sharing the slides afterwards, but we really think it should be have a strong emphasis on everything that we do from a patients included perspective. Too much of the innovation that's going on still is without the patient, the family, and the informal care present. So I had a great chat today with Brett Burlington, who's one of the patients that spoke together with his wife, Diana, on one of the Exponential Medicine conferences from Daniel. And also in their sharings today, again was that the expertise of the patients and the informal care and the family is still not taken into account in regular healthcare, let alone also in innovation. So I really do think that there's an opportunity for that. So what are we going to do? We really think that we should emphasize on 3 pillars, actually. From one end, to explore everything that we could do together. Obviously, there also could be some competing interests, but we have to figure out how to work past those. Secondly, we want to learn together, to learn and to translate all the insights from the first part, but also from the doing stuff side, which is the next pillar, also to combine it and to create frameworks that might not work in Singapore, but do work in Palo Alto, or do work in Canada, or do work in Germany, for instance. And that's one of the things that we really try to do. So in a round that Zeina and Jules made throughout the founding members and asked what you think that from the exponentials would be a priority of interest to all of you. And I'm scrolling fast forward to another slide for a second and get back later on. So this is what they came up with. And so as you can see, there's some similarity from one end, but there's also differences in it. So what we did in the end is that we said, so these 7 principles, these 7 exponentials, which are the green ones, should be the first ones to emphasize on more and try to get a hold on everything from a GNHIC perspective. So we've created a website where you can find some of the stuff, and we're trying to build that on over the course of the next months, of course. There's already some great Flipboard content that you can find through the link just below here as well, and also some of the Pinterest boards that you can tap into. So from the do perspective, we're choosing to set up a digital research center where not only the playbooks come into place, but we also try to form small clusters with members that would jointly take up 1 or 2 of the projects. So for instance, St. Elise, together with Kaiser and Carolinas and Radboudumc, we are working on AI technology vendor, exactly the same, which is X2 AI. Interesting enough, if we could combine that, not only from a buyer perspective, but also to pursue the innovation into the next level, that could be a very interesting perspective for that. And we want to really emphasize on that. This is the slide that I was sharing already. So what's next? What's the timeline? What's the goal for 2017? Like I said, I asked Zaina to take it into the next level and try to disseminate everything that's going on already and to talk to each and every one of those. Secondly, that's exactly where we are right now. And we also have some kind of a soft launch for that. Secondly, the next thing that we would love to do is that in August, September, we want to convene not only the Tech Tuesdays as we have right now, but also to continue within those 3 pillars and to iterate. With the aim that in November and October, we will host the ILN conference in person, and also from another initiative Zaina and I took on, which is the Health Innovation School. A lot of people, CEOs and future leaders from healthcare in the Netherlands will convene in Nijmegen combined with the ILN conference. So that's a great moment and time, and maybe I can switch to Zaina in a couple of seconds to explain a bit more on that, because there still is room for some of you to join us in that. Next, we also want to determine the forward model at the Exponential Medicine conference in November that Daniel runs, to really have the inaugural meeting and to really to kick it off and also make the choices that we need for that. Let me pause here for a second and switch over to Zaina to share a bit more on the ILN conference and the opportunities that we got there.
Thanks, Lucien. I'll actually pass that on because I think Gloria will get into it in just a minute.
Okay, that's fine. Good. So with that, I would love to round up. Again, the slides are available not only in the recording, but also afterwards in the Slack channel. And I would like to hand over to my great friend, John Mattison, who is not only core faculty and heavily involved in everything that's called innovation within KP, but also is able to explain very complex stuff to a lot of people in a very understandable way. John, take it away, please.
Thanks, Lucien. I'm trying to share my screen here. Do you see my screen yet?
No, you should take the...
How about now?
Yeah, now we do.
Great. Okay, thanks for the kind introduction, Lucien. And Daniel, Lucien, and many on this call have contributed pretty substantially to the adoption of exponential technology in healthcare. And I'm going to talk a little bit about some of the examples that we have. So almost every one of the exponentials that Daniel and Lucien referred to are the subjects of projects at scale in Kaiser Permanente. Some of them very early, some of them fairly advanced. I'm going to talk about a couple of the lessons learned along the way. And my slides are not advancing.
I think you can use your cursor, John, try it.
No, that's not working. And my down arrow's not working. There we go. Okay. So a couple of road hazards on the exponential journey. So the first thing, that in a large institution with lots of executives, the bright and shiny object syndrome can be challenging. And one of the critical issues of managing an exponential project is to manage up, to make sure that you're in sync with the key executives involved in that technology or in supporting that technology. Seems like a simple process, but often it gets very complicated in a really large institution like ours. We have 190,000 employees at Kaiser Permanente, 20,000 physicians, and so managing the enthusiastic crowd can be a challenge. The second one is similar in that the ownership of the cool exponentials can actually introduce friction between potential collaborators. So building a deliberate culture that supports what I call a plecosystem approach is key. So the plecosystem refers to the multi-platform ecosystem that we're all operating in right now across the many exponentials. And really individual exponentials, while sometimes create enough pull that they can be embraced, adopted, diffused, and scaled alone, it often requires the integration of several exponentials to make it happen. And if you don't have a plecosystem approach that supports collaboration among people who operate in different silos, that can be an impediment to success. The third is managing the minimum viable product, which frequently bloats from too many cooks in the kitchen. So a very deliberate management of creating a minimum viable product is actually a team sport and is critical to subsequent diffusion. The next road hazard is how to build and maintain cross-skilled teams, which is a necessity in the exponential space, and translating between different members of that team, which I refer to as a metatopical brain forest, people with different disciplines together collaborating at the boundaries of their disciplines, is a skill that is not necessarily inherent in large institutions. The next road hazard is recognizing that a lot of disruptive innovation comes from the edge, and the edge is frequently outside your organization. And as someone once said, most of the smartest people in the world don't work for you. So it's critical that we resist the urge to invent too much of what's being done external to the organization. What large institutions can do more effectively is learn how to operationalize the technologies to a greater extent than actually developing the technologies themselves. And then finally, and Lucien referred to this as well, there's lots of problems to solve. Focusing on those that have an exponential impact on our patients and members and physicians and care delivery teams is critical. So I'm going to talk about just 4 examples. As I mentioned, we have many, many more, but a couple of those lessons learned with a few exemplars. So machine learning, I started putting together a machine learning team almost 20 years ago, and have brought together a team that is truly world-class at natural language processing. And it illustrates a couple of things. So if you look at Watson as an example of applying NLP at scale in healthcare, it's been a long ramp-up time for them. And part of that ramp-up time has to do with getting the cross-skilling team together. So we started off by bringing in people who had skills at clinical operations, clinical care, informatics itself, and the deep technical aspects of natural language processing, and put them all in one team so that they could leverage information in ways that were relevant. And there's a lot of components to make that work. There's a lot of efforts aside from IBM to make this work with variable success, and a lot of that success depends upon how well you construct that team. So the example I'll give is Pneumovax. So I read an article in New England Journal, I don't know, 5 or 6 years ago, about how half of all people who had had their spleen taken out were not appropriately vaccinated with pneumococcal vaccine, which is life-saving. And so I asked both my discrete data analysts as well as our natural language processing analysts to identify those who had had their spleen taken out, which usually happens at seen elsewhere, so not in our records, not a coded diagnosis often, but where there may be some free text. And when both of those teams went at the problem, they got very different results. They were overlapping, but they identified different populations based upon how that data was entered. And then we were able to determine which of them had and had not been vaccinated, and were able to go after all those who were not vaccinated and appropriately vaccinate them. So it is the combination of the exponential of NLP with conventional discrete data, relational database searching, and the metatopical brain forest of that particular team that is critical to be able to achieve these kind of results. And the Pneumovax is one of many, many examples of how we've used natural language processing at scale across the program. In telemedicine, a lot of hype about telemedicine, a lot of confusion about what works. And the important thing here is to recognize the right horse for the right course. So what you don't want to do is introduce the overhead of a video visit when a few emails or text messages or in-app messaging or a phone call is just as good. Technology is the easy part. It's working out the staging of how do you make sure that the patient is ready at their telemedicine station at the same time the physician is ready at their telemedicine station, so that there's not a lot of wasted time getting things connected. But also what we're doing is we're instrumenting everything we do so that we can understand which modality of communication is the most effective to achieve the best outcome, both in terms of quality of clinical outcome as well as satisfaction and patient safety and cost. So putting all of those data sets together is critical to help us understand how to do intelligent routing between the different modes of telemedicine to support high quality, low cost care. The third example I'll use is remote monitoring. So with all of the sensors and the quantified self and quantified health that Daniel referred to, it actually is very easy for a consumer to generate tons and tons of data, which in itself becomes a problem because the signal to noise ratio can be unbearable for physicians who are already overwhelmed with too much data. And so being able to filter the signals to the noise and highlighting what is an outlier event for an individual patient is critical. And then addressing end-to-end workflows. How is the information reviewed? How do you put in time bombs to know that something is critical enough that it needs to be addressed within a certain period of time? How do you have the staffing to be able to manage that information in a timely basis, et cetera? All of those things are critical in the remote monitoring space. And despite some of the meltdown in the remote monitoring wearable quantified self space from a commercial perspective, I think many of us are still incredibly optimistic about the future of this when we work through some of the workflow issues and some of the signal and noise issues. But those two are significant challenges to bringing that exponential technology forward. And then finally, open notes. And Lucien kindly invited me to speak about open notes at Radboud recently. And one of the key messages I've given there, so those who are not familiar with open notes, is where you give every single person instantaneous access to all of the information about them. So when a physician or a pharmacist enters something about a patient in the chart, it can be instantly available to that individual. And we now have thousands of physicians who are doing this and millions of encounters where the instant the note assignment goes to the individual. Seems really simple. It is really simple. It's out of the box capability for most of the major health record vendors now to flip a switch. There is an intuitively obvious fallacy, and that fallacy is if I let my patient see everything I do the moment it's done, I'm going to be inundated with phone calls and questions and additional work. And that fear is universal and overwhelming, but it's just not true. And so applying the principles of evidence-based medicine to this field has been one of the biggest challenges. There is no reason why every institution that has an electronic health record today does not provide open notes for every single patient that they serve so that there is engagement. And one of the things we tell our physicians is don't dumb down your language. Use exactly the language you used previously unless you want to use it as a communication vehicle to explain things. But the truth of the matter is patients will look at that, go to the web and understand any jargon that you use. So next time they're in the office with you and you inadvertently use that jargon, they actually understand. So those are some of the diffusion and spread and cultural issues around creating exponential success within a large healthcare institution. And I think, Gloria, you're up next.
I am.
Take it away.
Right, I'm going to share my screen. Thank you very much, Daniel, Lucien, and John for that. So I have the distinct pleasure of spending the next few minutes to share with you how this amazing collaboration came about between the Innovation Learning Network and GNHIC. So as the Emerging Technology Group of the ILN, it's my responsibility to keep tabs on emerging technologies and trends that have significant impact on healthcare and share them out with our network members through a series called Tech Tuesday. I think many of you may already be familiar with it. This this series actually was launched back in February of 2015, and it is a monthly virtual session dedicated to educate and inform the ILN community about emerging technologies and their application in healthcare. Each session features a subject matter expert and covers a wide range of technology subjects, such as IoT, virtual and immersive technologies, and robotics. These sessions are educational in nature with an emphasis on technology and use cases. And it's really designed to not be a marketing or a sales pitch for an organization. So some of the examples I mentioned earlier, here are some of the past Tech Tuesday topics, which include robotics, AR, VR, artificial intelligence, 3D printing, predictive modeling. Our next few sessions will focus on immersive patient education platforms and an innovative consumer-centric payment platform. So at the same time, though, what we didn't realize was around mid to late 2015, and Lucien mentioned this already, the REshape Center had convened innovation leaders from leading-edge health systems in a workshop at the Singularity University Exponential Medicine Conference in San Diego. So from discussions and debates, many of the challenges innovation centers in healthcare all around the world faced they realized they were the same. So they decided, why not collaborate more? And so the group basically aligned on the need for a particular attention to the potential impact of these exponential technologies in healthcare. So this led to the birth of the Global Network of Healthcare Innovation Centers, also known as GNHIC, and it's an effort that's led by the Radboudumc REshape Center. REshape agreed to take the ideas away and soft launch this network in 2016. And Zaionz took the charge of launching this particular network. So, and as I'm not going to go into this much, but here's the 7 focus areas of GNHIC, and we will share more information about the network and what is taking place there with you after this call. And here again are the 3 streams of activity, or the pillars that they really focus on. And when we started exploring with this, what we realized was they actually align very similarly to the ILN Tech Tuesday pillars, which ours is really focusing on emerging tech exploration, design and development, which is around the collaboration piece, and and the technology spread. So how did this whole thing come together? Well, Zaina, being the driving force behind GNHIC, and she's also an advisory board member of the ILN, saw an opportunity for these 2 great networks to actually join forces and to create a platform for technology futurists to plan and prepare for the impending arrival of these exponential technologies in healthcare. So as you can see, there are actually a number of leading health organizations that are members of both networks. Some of the ones included here include NHS, Mars, St. Elizabeth, Massachusetts General. We have Carolinas, VSP, and Kaiser Permanente. So what we just hosted today is the very first kickoff and the first edition of this new collaboration between the 2 networks. Over the next few months, we will feature 1 topic per session, starting with VR and moving on to other hot topics such as voice, AI, blockchain, robotics, etc. And you can see below are the dates of each of these sessions, and welcome you to join us. And as you join us and you're embarking on this journey of looking at different exponential technologies, we welcome you to tell us about what is happening, because again, this is an opportunity for us to meet other like-minded individuals and also, learn from each other and explore what this means to start to work with these exponential technologies. And last, we mentioned this a little earlier. So what is going to happen next? The ILN and GNHIC are actually congregating in October in Nijmegen to continue this conversation. So come and join us during this in-person meeting scheduled for October 17th through the 19th and take part in conversations around exponential technologies. If you need more information, I have included the link here below. Please take a look. You'll have high-level meeting agenda, and if you're interested, you may also register for the meeting there. So with that, this takes us to the Q&A time. And again, I want to say thank you so much for our panelists that joined us today. I have a handful of questions that have come through during the talks earlier, and what I want to do is also open up the time for any of you that may want to take yourself off of mute to go ahead and ask that question directly. I also, actually I have a note here from Zaina. Zaina, do you want to jump in and tell us a little bit more about these Exponential Tech Tuesday sessions before we move into the Q&A?
Sure, I just put a note on it. We're going to try to have each session, when we focus on one of the exponentials, to have 4 parts, so very structured, kind of like today. The first will be kind of one of the top gurus on the technology, AI or VR, so not a health expert, but what is this platform? Second will be an expert on why is it relevant to healthcare? What's the landscape? What's the state of the state? The third will then be somebody like what John Mattison just did, one of the members of the ILN or GNHIC, explaining what they're doing today to deploy that exponential in the field, in practice. And then the last, we will profile and talk about an emerging tech innovator that's bringing solutions to patients today. So if you've got any ideas or suggestions of who could fill that docket, reach out to us.
Thank you so much. So with that, I'm going to kick us off with a few questions that came through. And again, for anyone who is interested in taking yourself off of mute, please jump in and join the conversation. So the first question is directed at Daniel. The question has to do specifically around when you talked about different apps in the App Store. The question came from Samuel asking, why aren't there more apps in the App Store that assist in self-diagnosis? And John, John and Lucien, please feel free to jump in and answer this as well.
Well, that's a great question. I mean, there's probably 60 or 70,000 health-related apps on the Apple iStore and on the Google Android platform. And, they cross the spectrum from just having data to connecting young mothers to different sorts of clinical elements. And some are moving into the realm of diagnostics. Of course, it's a challenge to have something that needs to be accurate and reliable. And diagnostics is still a bit of an art, depending on the clinical realm. And it's been a challenge in how do you regulate an app. If you have a diagnostic device and you want to sell it in a pharmacy or through a medical store, to have it FDA approved, has to go through steps to show that it's measuring the blood pressure accurately or measuring your heart rate, etc. And so while there's an explosion of little diagnostic devices like the classic AliveCore case that can record an EKG, that's had to go through FDA testing. So before we start putting self-diagnostic apps out there, they need to be carefully built with, I think, regulatory guidance. The FDA actually has been thinking hard about how to regulate apps and how to treat software as a drug, as a medical device. Software as a medical device. Just in the last couple of weeks, the FDA announced some new initiatives to fast track and help catalyze managing software and apps. We actually had a whole session at Exponential Medicine last fall with Pakul Patel, who's the lead heads up digital health for the FDA, and we ran some brainstorming sessions to bring other mindsets into that. So the whole Exponential Medicine and other communities have been helpful in catalyzing that. But it's not a simple question or a complete answer. I think we'll see more and more chatbots that evolve that help you do triage, but they're not going to tell you you have diabetes, etc. Some of the more paired diagnostics, like an EKG now, can tell you whether you're in atrial fibrillation. That's a diagnostic. But those have gone through a lot of hoops and regulatory elements. So lots of potential as we see telehealth and other data converge. I think we'll see a lot of more point-of-care diagnostics on our smartphones and apps, but we need to be careful about how that rolls out.
Yeah, and this, John, I'll add. I agree with everything Daniel said. I'll add a couple of comments. There are a number of pretty advanced chatbots that are being brought to market now. I won't name them because if I only name some of them, that would be a disadvantage to the rest. But the truth of the matter is that the effectiveness and the accuracy and the utility of them relies a lot on having a complete set of information to operate on. And so what we're building towards is the ability to, when one of our members calls in for self-service on a chatbot, that we have access to their complete medical record in the background, so decision support can apply not just to the symptoms they're presenting at that moment in time, but to everything we know about them, because we all know, and there's good literature showing, that we forget a lot about what has happened to us in the past, and it may be incredibly relevant to an acute problem that we're exposing to a chatbot. Second thing I'll mention is, as Daniel indicated, the FDA is very interested in fast-tracking a lot of these products and trying to accelerate their entire review process. One of the things that's really challenging about the machine learning that sits behind a chatbot is that most machine learning infrastructures have a very large feed-forward component. That is, they prune and then feed forward without a lot of feedback. The feedback in a machine learning neural net actually is where you can produce some traceability to have some insight into what actually happened rather than a purely black box approach. So there are both hardware and software vendors in the machine learning space who are beginning to focus on that feedback portion so that there is more traceability and understanding of exactly how a conclusion was reached. And the last thing I'll mention is Larry Smarr, who's another faculty member at Singularity University, is putting together a lab right now of the various hardware and software contenders in this space to produce objective findings about what neural net infrastructure, what processing unit infrastructure that is optimized for a particular problem, a particular set of data, and a particular piece of hardware is going to be most efficient at solving a particular problem. So for the first time, we actually have a legitimate, objective third party looking at some of these very issues that the FDA will need to regulate. So I think it's a question worth this elaborate response, because it will be one of the most disruptive things to hit healthcare, because it's not that far off where we will be able to offload a lot of things safely into a self-service environment that currently consume a massive amount of resources in the healthcare delivery system.
Thank you for the answers. We actually have quite a few more questions, so I'm going to run through them quickly, and if I can ask the panelists if you can touch on it really briefly, and then if we need to, we can continue the conversation either on Twitter or we can take it offline. And so we do have a Lucien suggested that we answer in tweets, 140 characters. I like that. So we do have a question from Tim Rawson. Tim, are you ready?
Yeah, I'm here. This is Tim Rawson with the Innovation Learning Network. This is for the panel, whoever wants to answer it. So exponential technology as a term is relatively new to me. So to prep for this, I went back and looked up some information on it. And what I found was the 6 sort of phases of exponential technology, and one of them being deception, the deception phase, which I thought was very interesting. And I guess my question is, one, could you just for the group, could you briefly, if you could, explain that phase? But then also, I guess my question is, how do we make sure that the technology that we're developing or working on doesn't get trapped in that phase? Do you think that's where the segue is right now? No, I'm kidding. That's fine. I'm just kidding. The segue will always be in the deception phase. But in terms of like actual health technology, how do you make sure it doesn't get trapped in that phase?
I'll just mention briefly, it's Daniel, that these sort of 6 Ds of exponentials. I think Peter Diamandis, who co-founded Singularity University, has sort of developed and popularized this. The first one's actually sort of digitalization, that, all these devices and services and things now, basically fit on an app. So they're being digitalized. And then it's deceptive in terms of how, when it starts to become really powerful. I mean, companies like Blockbuster thought they'd still be shipping CDs well into the 2030s. London used to think in the 1910 era that they needed to build more stables for horses, and we're even not thinking that cars were already there, but they were going to be taking over. What will be the deceptive elements of self-driving cars, as one example, even in healthcare. The third D being disruption, that can change elements. Demonetization, that when things like apps become free, you can maybe make everything from diagnostics to therapy relatively free. And dematerializing and democratizing, that we can spread these things around the planet. I think on the deception side, that the challenge is we often don't appreciate how, in 2 more clicks of Moore's law, how powerful AI might be, or how much more we can fit into a smart ring like this one that can track my sleep. How much more bandwidth we'll have. So that's where I think the deception is, and that's where it's hard for our linear brains to go. And where we need to be moving is to getting to see where the deception is early to help innovate faster and smarter in healthcare.
Great, thank you. And Tim, it looks like Zaina dropped some information into the chat box on the 6 stages of exponential technology. So Daniel, while we have you here, we do have another question from the participants. So they're asking if you can talk a little bit about, do exponential change typically come from top down, or is it more of a bottom up situation? And is there one that is more preferred by large companies, or is there a particular approach that would be, how do we manage it basically, when we're working for large organizations and faced with these exponential technologies and knowing that they're coming our way?
Well, I think first of all, many large organizations still are a bit in their linear mindset. There's an opportunity to leverage exponential mindsets in new ways across developing startups or large companies. One of my Singularity colleagues, Salim Ismail, has a whole book called Exponential Organizations. I think it's exo.org, which provides some context if you're trying to be in a particularly larger organizations, which are sometimes slower to adapt and change and can be disrupted by more nimble, fast players. Whether it's top down or bottom up, I think the key thing in healthcare is to understand the unmet needs, not to say, oh, I've got an AI or chatbot or some app or a wearable and say, I'm going to solve X, Y, or Z, but more to understand the problem from the perspective of the patient, the caregiver, the physician, the payer, and then look at what technologies are here and where might they be and how might you match them up in new ways to manage everything from adherence and tracking meds to applying smarter ways to bring all this new data and information to the physician, that last mile, the workflow part that John Mattison works a lot with at KP. How do you bring the information to the nurse, the doctor, the patient? So I don't think it's a bottom or top issue. It's more that we need to think about solving the problem in new ways, and not, again, to think everything's a hammer or I need to throw AI or some other buzzwordy technology at something, but to think creatively about how to bring them together to address a pain point that might be local. Here in the Bay Area where I live, we think everyone has an Apple Watch and Google Glass. It might be very different in Oklahoma or Tanzania or the UK or the Netherlands. So like politics, sometimes healthcare is local. You need to solve problems in a local way as well.
I think we have time for one more question. And for those other questions that we did not get to, I will go ahead and post these to our Twitter account and see if we can start a conversation with our panelists on the call today. So the question comes from Lyle Berkowitz, who is a doctor, and he's asking, how close are we to being able to fully automate routine primary care? Do you think it's under 5 years, over 5 years, over 10? What is your thought? This is open to all the panelists. And if we can do this quickly, I want to make sure we have enough time to do our final close.
So this is John. I'll take a shot at it first, very quickly. I think there are 3 different things that people seek in a face-to-face encounter with a primary physician. One is a better health outcome. The second is empathy. And the third is motivation. And so I think that we can solve the first problem with good outcomes fairly quickly, 5 to 10 year range, as Lucien put on the chat stream. I think that I agree with Lucien on that. But in terms of the empathy and the motivational aspects, while there's a lot of technology targeted at those two human interactions, I don't think that there will be a substitute. So what Daniel said at the beginning around augmented intelligence instead of AI, artificial intelligence, is going to allow us to spend more time on the empathic and the motivational side of the equation.
Well, thank you, John. The only thing I would like to add to that is that I completely agree. However, if you talk to patients about what matters the most to them, and you also see that from a social medicine perspective, you could question whether or not that would be the task of a physician. Or that, for instance, a good and well-trained nurse also could take part in those kind of things, having more time freed up also for the physician to take on the harder cases. What we'll see, I think, not only from a technical perspective, but also from more and more well-educated patients, that they will become experts in having the disease themselves already. And that's to the question of the question from Lyle, specifically aimed at primary care, really will change and shift primary care as we know it right now. Although there are differences between the US systems and, for instance, the system in the Netherlands. But I think that there's a huge opportunity, or maybe even also pitfall, to automate a lot of those things that we'll come to about very shortly.
Completely agree.
And with that,
you and me are agreeing on something, John? Did I catch that? Okay. Wow.
Yeah, you heard it right.
Yeah. So thank you all, and I'll turn this back to you, Cynthia.
Great, thank you, Gloria, and thank you, Daniel, Lucien, and John for joining us this morning and evening, depending on your part of the world. I just wanted to remind everyone that today's session was recorded and will be available on our member site later today, so please check out members.iln.org. We will also be sure to post any of the resources that were linked in the chat box so that you can follow up at your leisure. And if you are not an ILN member but would like to continue with the Exponential Tech series, or just have questions about who we are and what we do, please visit us at iln.org. Our next two sessions are as follows. On Thursday, we will host Virtual Thursday on AIM, Envisioning New Models of Service Delivery and Engagement in Healthcare. And on August 29th, we will be hosting our next Tech Tuesday session, Next Generation Patient Ed, the next big thing in engagement. Thanks again for joining us, everyone. Have a wonderful Tuesday.
Bye-bye.
Bye-bye.
Thanks.
Bye.
This is how healthcare should work, right? This is healthcare innovation.
Bye, guys. Thank you so much, you guys.
Oh, that's a great way to end, Lucien.
Great to see you guys. Thank you, Zena. Bye.
Bye, guys and girls. Thank you for everything. Bye-bye.
Thanks. Bye.